Thank you all very much for coming. My name is Carl Couch, as Van said. I'm going to talk with you for about 15 to 18 minutes, and tell you a little bit about Baylor Quality Alliance. Along the way, I want to introduce some of the folks that are in the audience that are associated with us. And then I want to have plenty of time for questions and answers and still get you out of here by 6:30, 6:45. We started just a few minutes late. But I really appreciate your being here, and I hope that the information we talk about is useful to you. You know, I think most everybody in the room, just going around and talking with you beforehand, realizes that healthcare is in a lot of change right now. A lot of changes in the wind. There's a lot of things being talked about, a lot of uncertainty. My personal observation is that physician practices are under a lot of challenge today. Rising costs in the practice with no rise in reimbursements and not much of that in sight. And so there's a lot of stress in just operating a medical practice today. At the same time, there's all kinds of mandates coming our way in terms of things we've got to do, in terms of quality metrics, in terms of compliance metrics, and so on. So healthcare is undergoing a lot of change. The same changes apply in the hospital today. And the hospital is facing a great deal of change as we look at what's going on. So I wanted just to kind of tee up some of the reasons of what we're about, why we're doing this, who we are, and so forth. So let me progress into that. The changes that will affect us all will be very real. I was talking with a group of radiologists last week, and they said, well, that's about the way it is, that we assume that big government and some of these changes are going to make it very difficult to practice medicine. I personally am much more optimistic than that and think that what we're wanting to talk about tonight are some solutions to some of this, and hopefully you'll be interested in that. The WHO is Baylor healthcare system, the hospitals of the system, physicians, and even post-acute care providers are going to be asked to join BQA. The physicians we want to join BQA are those that want to affiliate. They want to be part of a clinically integrated effort to really attack the problems in healthcare, which we'll talk more about as we go through this. The three problems that are big, though, are the cost of care, the quality of the care that we deliver, and clinical integration, or the lack of clinical integration, which is the problem. And so doctors who want to come together, willing to work together, willing to collaborate on care paths and protocols and evidence-based standardization on the things that we do have good evidence for, so that we can benefit our patients, so we can avoid waste and provide a more seamless experience for our patients. We have a board of directors that's met now for 6 months. I want to just take a second to ask them to raise their hands. Dr. Randy Krim, a colorectal surgeon, is on our board. Van Lam, who's just introduced me, and thank you, Van. And then Bill Plummer, who is a non-physician who happens to be Nidra's father, but also is a non-physician member. This is very important because actually Medicare certification as an ACO requires that you have a non-physicians on the board who actually represent the voice of a patient. So I don't mean to make you get sick, but we want you to represent the voice of the patient. Also in the back, two fellows that assist me a awful lot, Bruce Miller and Jack Tinsley, and we're really glad to have them. And Michael, thank you for being here as the president of Carrollton. So very much appreciate you all being here. The board itself is intentionally composed of 14 physicians and 5 non-physicians. It has to have a physician majority board. We have a physician chairman of the board, Dr. Packard, who happens to be an emergency physician. Most of the physicians on the board happen to be specialists. I have a background in Health Texas, although I'm no longer affiliated with Health Texas. Health Texas was created largely as a primary care organization. And we recognize that BQA is going to be many more specialists than primary care, although primary care physicians are also very welcome to join BQA. We want both. But there are more specialists there than primary care. We want you to know that it represents a voice and a perspective that you'll want to have represented if you happen to be a specialist. What is BQA? Well, as I've said, first of all, it's a voluntary alliance. People coming together saying we want to work together, we want to collaborate. It will include employed physicians. Many of the Health Texas physicians will join. It will include many independent physicians. Baylor medical staffs have 4,000 independent physicians across the system. And so we are seeking for any of those physicians that are willing to come and join us, because membership is open at this time. We're going to come together and work hard on several things, on an approach to the populations that we serve, on very well put together information systems so that information on the care of the patient can track from one venue to another. Even though we may have disparate information systems that we work in, be able to link those together through health information exchange technology. We're serious about analytics, about being able to bring meaningful data so that it'll help me be a better practitioner, help me do a better job with the patients that I see by knowing my own practice performance in the areas of both cost and quality and integration of care, and we intend to measure those. We know that we can achieve some very interesting contracts, and we'll talk about payment mechanisms, because BQA is poised to accept some of the different kinds of payment mechanisms that are coming. Many of you may realize that payers are shifting risk gradually to the providers. And this is part of Medicare's strategy, is part of the commercial payer strategy, and that is to gradually put more and more risk on the hospitals and the physicians in terms of the cost of care. Part of that is going to require that we come together and that we create a seamless experience and that we avoid waste in healthcare, of which there's a good deal. Berwick, the guy that was the CMS president who just left CMS, is well on record by saying that he firmly believes 40% of all healthcare cost is waste in the United States. And most of us know where that waste is. We see it every day. Information that doesn't track with the patient, tests that have to be duplicated and repeated, sometimes unnecessary tests done for reasons other than just patient care. And so there's a lot of waste, and there's tremendous opportunity for us to begin to deal with that and still take wonderful care of our patients. The goal of BQA is to have high-quality care, to reduce the overall cost of care, and to do it by integrating the care that we in the way that we serve our patients. We're going to be concentrating our efforts basically in Baylor's primary market areas, and you know what those are. It's one of the reasons we're here, because Carrollton is such a vital part of that. And so we will at least initially organize ourselves around our market areas. But we have other affiliates further away, in fact a couple of them here tonight, that are from outlying hospitals that are not part of Baylor, and we're going to seriously seek to have relationships there to extend that influence further. Baylor is also involved in a Texas-wide alliance that we're part of. And that alliance is beginning to take some concrete shape, and so there will be affiliative relationships even beyond our 10-county market area. But for now, this is the way we portray this. The BQA has existed about 6 months. Our board of directors formed about 6 months ago, and I'm very proud of these men and women that are on our board that have come together, and they're really beginning. We've asked ourselves questions like, what does clinical integration look like? How's it different than the way we take care of people today? And so the image of what that really means begins to take some shape. We all know, in fact, if I ask for a show of hands, I know what the honest show of hands looks like in any audience. How well integrated is care? If I asked you, have you ever been through a serious illness with your family, somebody in your family? And if so, how integrated was their care? How much did all the pieces connect? And most people would say, well, it's not integrated. I had this excellent experience over here, and maybe this excellent doctor took care of us over here. But the reality was the gaps in between were huge. And if it wasn't for you as a professional person, you probably became the integrator, because that's the only way it happened. That's the only way it really works today. We don't have a system. We have silos of excellence that don't always talk to each other. And so the goal is, how can you come together and smooth that out and make that experience different? And I think by working together, we'll be able to achieve that. The BQA has formed 6 working committees that are actively engaged right now around our Membership and Standards Committee, a Population Management Committee, a Finance and Contracting Committee, Compliance Committee, and just to name 4, also an IT committee. And so these committees have begun to really be active and are really trying to lay down the infrastructure of what we see happening. One of you asked me a minute ago, where are we in this? And I guess my best analogy today is the airplane already has taken off and we're still putting the wings on it. So we know we're assembling this as we go. And so it's not a completely baked pie. And those who join BQA will be influential in helping to shape what it's going to look like as we go. Beginning this month, we're beginning our town hall meetings to acquaint doctors with this, to invite membership, which you are invited tonight to consider that. And we know we'll be operational, that is, taking care of populations of patients, no later than next January and probably sooner. We're very close. Within the next month, the board will decide, are we going to file for Medicare Shared Savings designation? And if so, we will participate with a Medicare population this coming summer. Regardless of that decision, there are several other contracts that are available to us through other Baylor sources that we can appropriate into BQA if we choose to do that. And by January of next year, the Baylor system workforce, which is about 35,000 employees and dependents, will use BQA as a preferred network within the Aetna circle. And so that's been pretty well agreed, and I think we will definitely serve that population no later than then. The why of this, I think, is important. The three compelling reasons, cost, quality, and the lack of integration of health care, are definitely real. I had 2 employers sit in my office in the last month saying, are you really going to do this? My workforce in my business, we are so stressed at the cost of care that if something doesn't happen to begin to stem the rate of rise of increase that I'm facing every year as an employer, I'm going to drop out of offering health insurance to my employees. I'm going to send them to the insurance exchange in 2014. And people are saying things like that. The McKinsey survey about 4 months ago said 40% of American employers are taking that stance. So what we see is this unending stream of commercial insurance is really under stress. And it's under stress because the people that pay the bills are the employers. So cost is huge. It's the 800-pound gorilla in all of this. Quality continues to be a problem. We've made great quality gains in Baylor. I'm proud of the fact that in the last 5 years, the work of Best Care and the work that you all have done, and you all have had some sterling performance on your quality indicators recently, but we've dropped mortality in the Baylor healthcare system inpatient by 49% in 5 years. That's incredible. It's wonderful. It's world-class. We're delighted with that. And yet, still quality problems exist throughout the United States, and nonetheless at Baylor. Some of those are just as simple as the fact that heart failure patients often have to be readmitted too often. Nationally, it's 22%, 22 to 25% will be readmitted in a month. With any sort of a heart failure clinical integration program in place, you can drop it to 12 or 10. But we haven't done that effectively across the whole population of care. So we've got quality problems that still persist. One of the ways of looking at populations is first of all to realize that populations tend to be heterogeneous. All populations fall into different categories. It doesn't matter whether it's a commercial population, Medicaid population, Medicare population. These kinds of numbers are pretty universally the way it is. If you look at the center triangle, if you look just at the top part of the triangle, 5% of the patients in the United States and in any given population drive about half the cost of health care. That's both a problem and an opportunity. The problem is the cost. The opportunity is it's unmanaged completely. That group of patients are sick. They have 5 or 6 diseases. They have 5 or 6 doctors. They have nobody in charge. And so they bounce in and out of your emergency room, in and out of your ICU. They're very, very difficult. And yet their employers and any sort of payer group are crying, would you please take that population on and do something about it, because there's great opportunity there. So we're already being approached by that, by the payers for that very reason. The rest of the population, which is healthier, one of the things that we've got to do is have the capability of not only knowing who's in the most acute serious part of that triangle, but knowing who in the bottom part of that triangle is likely to migrate, because people migrate through severity of illness. And so how do we predict who's likely to become sicker and put resources in place to take care of them? I'll give you an example of the kinds of resources the top group needs. We have a doctor in Baylor who is a geriatrician, wonderful physician. She has about 1,100 patients. She has 3 nurse practitioners. Her patients are frail, elderly. She happens to also be a board member of BQA. Her patients are elderly. They're end-of-life patients, very frail elderly. Her patients, 90% of them die at home. They never even go into the hospital. They all have advanced directives. Her patient satisfaction is off the chart, and she saves Medicare more money than you can imagine, but she requires subsidy in her practice. She has 3 nurse practitioners. She has to be subsidized because in a pure fee-for-service environment, it doesn't pay its way. But she's managing these patients across the continuum of care. So the ability to change that, which I'll talk about in just a second, is huge because she brings incredible value, but her value is to the patients and to the people that pay the bills, Medicare. And so it's a real challenging situation as we look at these populations. We've got to be able to bring those resources where they're needed. A couple more slides and I'll hush and I want your questions. I'm going to tell you just a little bit about what we see as a strategy that we'd like to approach BQA with. There are 4 parts. The first part has to do with what we call the entry point of health care. I'm a primary care physician. I know there are others in the room that are. And it's my firm belief that everybody needs a primary doctor. And frankly, the more health problems you have, the more you need one. And in today's complex environment, it becomes even increasingly important. We see a patient-centered medical home as being pretty foundational in the care of any individual patient. That's usually a primary care doctor, but as my renal medicine colleague and I were just talking a minute ago, I think in some situations it could be a specialist who's willing to take care of that patient as a primary, for their primary needs. I think sometimes renal medicine, maybe some oncologists, maybe definitely obstetricians may want to be designated as a medical home. That's fine, but with that comes some accountability to really meet that patient's needs and make sure, if you're not actually doing it yourself, that you're firmly connecting the dots. Okay, it's critically important that people have that resource, and I believe that. And if you look at the literature across all this business of clinical integration, medical home is very, very important. We've got to be able to resource medical homes a little differently. As a primary care doctor, most doctors have doctor, medical assistant, receptionist. That's kind of the model, isn't it? And the way that it works is when you're in front of me as a patient, you're on my radar. When you walk off, you're off my radar. I'm seeing my next patient. That doesn't do much in terms of managing illness across the continuum. And so how can we help bring resources to the primary care practice to help them manage that patient's needs across the continuum? Reach out and deal with the gaps in care. Give advice over the phone. Take care of the non-reimbursed services that are absolutely required in disease management today. Well, that's going to require different payment mechanisms. Most insurance companies in Dallas are laying on the table. We will pay a primary care bonus for some of that care management, and in addition be willing to reward the practices with shared savings. This is a foundational part of the strategy and one that we're happy about. We've got over, I think by this summer we'll have 300 primary care physicians who have agreed to be part of BQA. Second part is specialty alignment. That's really the work that BQA is involved in. It's around bringing our specialists, our hospitals, perhaps nursing homes, home nursing, rehabilitation centers, together into our alliance to create the continuum of care, working across evidence-based pathways that our doctors, you all, will help us to define and then implement and measure ourselves as to how we're doing with that. So that whole business of specialty alignment is just huge. We've got to all be working together. If we're taking care of a patient with low back pain, uncomplicated low back pain, I want the protocol that I follow to be the same one that the neurosurgeon follows, and the same one that the orthopedist follows, and the same one the physical medicine doctor follows. Because if we're working off the same evidence-based protocol, it gives a seamless care experience to the patient, and it will produce absolutely better outcomes. There's literature evidence of that. The third part is about the population. We just talked about that. Defining the population, doing predictive modeling, having analytics that help us to know where we need to apply resources disproportionately in order to take care of those patients. But without the last part, without financing, it doesn't work. Clearly, there are new methods of paying that are out there and being talked about. But some of those include shared savings. If you don't understand that model, it's basically looking at the projection of what health care costs should be for a population, measuring that against your actual performance, and if there's a positive variance, that positive variance is available for us to divide. And so we're anticipating shared savings contracts. We already have several that are being proposed to us, and Medicare is willing to offer one as well. The second model is bundled payment. That's being talked about repeatedly. Putting a single payment for the physician and the hospital into a same bucket, working together to create efficiencies around that, and if there's a leftover amount, sharing that amount. That's the bundled payment strategy. And many of the payers and CMS are talking about that. There's a Fortune 50 company in the United States 2 weeks ago said, if you're going to have a joint replacement, you work for our company, you're going to Baltimore and you're going to have it done at Johns Hopkins. It's an example of a bundled payment strategy with an organization that has said we can deliver high quality, high value care, and it was compelling enough that a large company is going to literally fly people over there to have it done. I think it's an example of bundled payment in the making, and we're going to see more of that. So this organization is prepared to at least consider that. We actually have a bundled payment simulation going on right now downtown with our orthopedists on knee replacement. No money involved, it's a simulation, but we want to see how we can do with that, and that's underway as we speak. Third method of financing that's novel, at least different, is the ability to accept some degree of risk. So partial capitation or degrees of capitation are in the future. I'm sure that as we get better at delivering a clinically integrated product, we'll be able to do that. And what that does is gives you access to the beyond fee for service to the pool of funds that it's partially going to take to run an organization like this and to create the structure and the resources we're going to need to practice in that environment, but also some additional rewards. Make no mistake about it, I don't think that there's a pot of gold out here. This is not a business deal. It's an opportunity to change how we do things, and I do think, though, that there will be some rewards shared, and most of our colleagues across the country that are doing clinical integration are experiencing small rewards that they're able to distribute back to the doctors. But it's no get-rich-quick scheme, and it's never intended to be that. It's intended to change the way we take care of people. The last part of this, and the last slide I'll show you, is where we are. I personally believe, and as I look at our physicians' faces, we're asking you to consider doing something, and that is to join an organization. And nobody changes unless they believe there's a need. So for those physicians that say, yep, I really do think we're going to need to work together, and we build that case reasonably well, I think that helps people to move. The second thing is to get ourselves organized, and we're doing that. We're definitely beginning that. We welcome you to consider being part of that, and then to let us gradually grow this thing and accelerate as we go along. So with that, I'm going to hush. I'm going to answer any questions that you might have, or try to answer them, and welcome your questions.